Thank you. Let me first start by thanking Dr. Kunti for doing this very elegant comparison. I remember, as Dr. Madhu also mentioned, there was a time that half the year people came and used to say, this is what's happening to Punjabis in Punjab and Punjabis in the UK, or Gujaratis in Gujarat and Gujaratis in UK. Now we started getting Gujaratis from UK into India, so that takes care of that problem. But let me now focus on the diabetes part. We'll try and stay away from obesity in this session. If you don't mind, we've had lots of fat and toxic fat in the first session. We'll stick with diabetes, and let me actually start off by saying that our problem is not merely all that has been listed in terms of access, in terms of the amount of control, in terms of attitudes, behavior. I think it's the entire spectrum. And therefore, solutions to management of diabetes in our country can't be restricted to, okay, let's find free medicines for everybody. That is not going to be enough. So let me start with one end of the spectrum, and maybe I'll request Gagan to look at that. So in terms of screening and early detection, what are the most critical gaps? Because that's where we need, as a silent disease, we need to identify people with diabetes. So let's start with that end of the spectrum. What are the critical gaps, and what are your thoughts on strategies to fix those gaps?
Thank you. I think one very important point that you've highlighted is, first and foremost, we're not picking all the cases with diabetes. There's a huge burden of undiagnosed and undetected diabetes, and also probably misdiagnosed diabetes. Our categorization, classification also seems to be incomplete. There's a lot of heterogeneity in how we diagnose people. Most of it is opportunistic clinic-based screening, or there's one side there are haves and one side there are have-nots. There are those people who are getting package tests done every month. Whether or not they have even borderline prediabetes, they are running around frantically. And at the other extreme are people with overt diabetes who probably are never picked up, or they might have undergone a testing in a medical camp and never bothered to consult again. So there is a need to we understand that systematic screening is required, but we have not incorporated it into our healthcare system at some point. Whether we do it through primary healthcare, that is one approach. But PHCs, of course, are overburdened, overwhelmed. Definitely, the National Prevention Program for NCDs does need to focus on systematic screening, and whether it's risk-based screening like the IDRS score was used. But by and large, most Indians now we consider are at a higher risk of diabetes. So maybe it's a universal screening that goes forward. And especially in categories like women during pregnancy. Again, that's an area where diagnosis is hugely missed, and very, very important implications for the future generation also. So one could be this primary healthcare screening, one could be community-based approaches, and also workplace. A lot of private sector now is doing workplace screening for these disorders, but still government sector, we don't really see too much of public screening going on. So that plus awareness is important. Awareness initiatives at the level of public, through social media, through community measures, these would really increase the engagement of the population also to come forward.
This very small follow-up question is, you yourself mentioned that people are told that they have a problem, but they often don't reach medical attention. Is there your thoughts on to improve that sort of last mile connectivity in that segment?
Yeah, so I think this is going to be one of the Achilles heel for all of us, because on the one hand, we have social media influencers and others, talking about why A1C of 8.5 also is normal. And then there are people running around with 6.1 A1C also worried sick. So awareness activities probably are required. Awareness of not just, what is diabetes, but what are the complications of diabetes. That would be the key.
Okay. So in the process of screening, as you rightly said, you will have people who will be normoglycemic, people who have diabetes, but you'll also have this midway pool of people with pre-diabetes, right? And there are enough, evidence through large-scale studies of how lifestyle interventions can actually prevent progression or at least delay progression of diabetes. Any number of years which you save is very important. Let me ask Shweta, who's sort of worked extensively in the field of public health nutrition. We have the evidence, but again, the issue is translating that evidence into, or implementing that evidence into large-scale health system practices, so that that person who's been identified with pre-diabetes doesn't progress, or if at all progresses, it's a slow progression to diabetes. What are your thoughts on that?
So thank you so much for the question as well as for the invitation to be here. I think this is very important, especially the studies which has come out from the ICMR INDIAB study, which is showing this large pool of pre-diabetic, not only in the adults, but also the Comprehensive National Nutrition Survey, for example, which documented that almost 10% of our kids, which are 5 to 19 years, are also pre-diabetic. And that is something which we don't even consider when we pack lunch boxes or when we, as busy parents, most of us, these are things which are seen as, even if the children are gaining weight, or there are risk factors which are overlapping, by the way, for pre-diabetes as well as obesity. I know, Dr. Tandon, that you specifically said that let's focus on diabetes here, but many of them come in a conglomerate sort of a way. So when we are talking about public health nutrition, I think it's very, very important to understand the dilemma of a normal person. Especially because of the time constraint, I'm going to focus on one thing, which is the digital food environment, for example. When we are talking about large-scale examples, please remember and bear in mind that it's not just one way in communication that people like privileged and elite people, for example, like us, who have privy to good education and doctors and all of that, will flow and will sustain. Even in our own households, so many of us, if I ask you right now, you will have diabetics at home, you will have obese people at home, and how many of them listen to you? Like when it comes to behavior change, it's difficult. It's very, very tough. So it's important to bear in mind that we have to, when we are talking about large-scale programs, think of the digital food environment. We always used to think, तुम्हें market में क्या मिल रहा है या government क्या policies दे रही है, right? Demand supply का चेन. लेकिन हम वो भूल जाते हैं that celebrities, endorsements, every mobile device these days is selling you something in some ways or the other. So I think a lot of the public health programs which are working on this awareness generation need to be very innovative, need to actually touch that, you stimulate that mind of yours in different ways. And for everybody, it's different. So there were programs which were IDP, with the Indian version of diabetes prevention program, for example. There was DCLIP program. These were also on pre-diabetic, which showed about 26% of benefits when we use lifestyle modification. 26% translates roughly 100 में 30 लोग, almost, को आपने बचाया. But there are also the 70% people who you are also struggling to make sure in the younger generation specifically. So I think in my limited experience of this area, you will need something which individual recognizes and understands as a family environment, at a community level, and then at a policy level. So some things are happening, but like you in your opening remarks said, siloed approaches would not work. Somewhere they have to coalesce, somewhere an integrated, seamless intervention package or toolkit has to be understood by an individual. And because we are so diverse, even within the, the smaller community that we are, there is so many people, so many different thought processes happening. We will need to, understand and integrate the most, what should I say, innovative approaches. Now, and in that sense, digital technology is something which I think is going to be the next big thing for pre-diabetes or for any other prevention mechanism.
So very quick and follow up with a short answer. Are you aware of any sort of community level upscaling of this evidence which is shown to work? I mean, we all have. You gave examples of the DCLIP study, you gave examples of other prevention studies. Those were done in controlled environments.
That's true.
They gave us very important information. Converting that into a setting, any sort of translated example?
Yeah, so there was this Chetna program, there was this Mark program. A lot of these programs have happened in school settings, Dr. Tandon. So schools are relatively close community, but at the same time you get somebody the children who are more recipient, and this is a good population. So this technology used in several parts of India, for example, or other countries, especially in the school health and wellness program. India has SHWP, which is a large-scale adolescent mind-shaping sort of program with the government, and they are using this intervention now. In fact, Novo Nordisk and WHO Foundation have just launched a couple days back, I think 3 or 4 days back, a big partnership on the SHINE program. Yeah. So again, there are model curricula, Dr. Tandon, as examples, but this is one thing that I would like the audience to know.
So I'm going to jump across and ask Kamlesh the next question. So the two things which you sort of specifically referred to, one was therapeutic inertia, which is a well-established fact, but you also seem to indicate that the therapeutic inertia there was more inertia in the South Asians when at least managing South Asians in the UK. Now, does that reflect a pushback from the population, or does that reflect a sort of a differential approach to people? That's one question. But in the same way, I mean, we also hear about this better response to anti-hyperglycemic agents among South Asians. There's going to be, and I anticipate by the end of this month, we'll have 50 brands of semaglutide out in India. Should we start a semaglutide for all campaign? Is that the best way of doing things? In terms of if you were handling a South Asian patient in your clinic, how would you prioritize algorithmically, which medication to start with, and how would you go along? So both, maybe you can answer this first and then address the inertia question subsequently.
Okay, we've recently just had nice guidelines published. We've now caught up with the times, and metformin, after that we're saying SGLT2 or even SGLT2. These are the organ protective therapies. Now they've become generic for many, many years in India, and I think they are probably should be with metformin the foundational therapies now. They are very cheap, and we know they have huge benefits, and not just in terms of reducing the glucose, but reducing cardiovascular outcomes, reducing kidney disease. Some data even showing in fat, some data showing in dementia as well, secondary analysis data. So I think they should be the therapies. GLP-1 receptor agonists, I'm a little bit worried about. We talked earlier that you certainly do lose weight, but 1/3 you lose is muscle. And Asians, we know, have less muscle. So if you lose muscle, they may protect you against your cardiovascular disease. So it may make you live longer. But you may be living in poorer health for longer later on because you become frail. We don't know that data as yet. So I do have concerns about it. I don't think it's for everyone. I think need to look at the patients and then decide who needs the weight-reducing GLP-1 receptor therapies. But the SGLT2 inhibitors, no doubt, they should be sort of first and second line.
Okay. Inertia?
Inertia is an issue everywhere. It's a global phenomenon we've shown in systematic reviews, occurs in every country. Seems to occur in whites and South Asians in the UK, but South Asians tend to get this more. And again, the reasons for this are very complex. South Asians, as I showed you, live in more deprived areas. The access may not be there. There are barriers with language. There are barriers with the health-seeking behaviors. So very, very complex reasons for getting inertia in the UK.
So I'm going to make a sort of small comment on this on the muscle bit. I don't want responses from the panel, and then we'll go ahead to the next question. I mean, there are also emerging data that the assessment of muscle impact can be actually divided between loss of muscle mass and loss of muscle function. And there also seems to be some evidence that at least part of the muscle mass which is getting lost is actually intramyocellular fat and not so much a muscle fiber itself. So I think the jury may still be out in terms of how severe the impact on muscle and muscle. So because sarcopenia is not just a measure of mass, it's also a measure of function, right?
Just a quick one. The other worry we have with GLP-1 receptor agonists, many patients stop it for various reasons, including affordability. The problem is when you increase weight, the weight increases, and weight increases very quickly when you stop these therapies. And when the weight increases, you get the weight back and sometimes overshoots the weight you were at baseline. But the weight you get back is mainly fat and not the muscle. That's another big worry.
Fair enough. So again, I think that brings us to another important part, which is for physicians to understand that the world has two sorts of disorders: acute finite care disorders and chronic care disorders. And very often in medical curricula, we've been entirely taught medicine as if medicine is acute finite care. People come, and it's happened in India specifically because infections being such an important part of what was afflicting the population. It's a 7-day course of an antibiotics. That's the end and nothing else. But the problem here is that we are dealing with chronic care, and maybe I'm going to request Parjeet to talk a little bit about two parts of chronic care. One is how do we maintain continuity? And we heard the word multidisciplinary care. How do you actually draw in multiple specialists? Or how can, for example, in the UK model, how can a primary care physician, without having to farm out the patients to another specialist, bring in their advice so that the patient's not running around all over the place, but you still manage to get the necessary specialist level of care for somebody, let's say, with diabetes who's developed a retinopathy or developed a nephropathy. So chronic care and then making multidisciplinary care more efficient.
So sadly, diabetes in India, I feel, is still being treated as an acute disease to be treated by a specialist. And that is what I'm talking about at the urban centers. I mean, you can just imagine what's happening in the rural areas. Here we are working at the tertiary care centers. Here also we are facing follow-up rates are very poor, adherence is very poor. In fact, patients who are very well educated, they have access to everything, knowledge, digital apps, and so many things. Even they do not come to follow-up. They're coming to me after 3-4 years and they're saying, Dr. Saab, everything was going fine. They just checked blood sugar once and twice and they felt everything was okay. And so the problem here is that one is definitely the lack of awareness. Proper structured way of education, which Professor Kunti was talking about, the diabetes self-management, it works in a huge way if we have that kind of awareness from the very beginning that this diabetes is a chronic disease, it needs regular follow-up and care. Answering your second question, sir, what can be done to improve the adherence and continuity of care? At national level, I feel we have some building blocks already in terms of NCD program. We have NCD clinics, we have community health workers, ASHA, and then we have some digital platforms like eSanjeevani. The problem is, in spite of all these being there, a 2021 survey did show that they're not well equipped. Like only 0.4% of rural settings and 9% of urban settings were well equipped to handle the NCDs. So we need to do some definitely more work there in terms of upgrading or maybe doing minor simple changes, as Professor Kunti was talking about, task shifting that training more nurses at the primary healthcare level to maybe at least, if not treatment, at least making diagnostics more smooth, taking care of simple blood glucose measurements, blood pressure, waist circumference, and also in empowering ASHA, the community health workers, giving them clear roles to play. See, as Dr. Gagar was also already, they are overwhelmed, so we cannot just give them vaguely the task to be done. Maybe the simple, clear roles, and in this, I feel digital health has a huge role to play. In fact, we have good data from India also, many programs where they have studied. If we use the digital health and ASHA assisted Like we assist them, provide them with a tab or a mobile health, and they can just, do simple monitoring, registries, reminders, going to home. Even if we can maintain registries, that make a huge impact. The impact study was upon that. Now, bringing the multidisciplinary team definitely needs a digital health there. We definitely need a technology there, and that's again the program. Sir, you are leading that program, iTrack program. CDSS is something we are looking forward to. We're clinical decision support system. If we are relying upon that, which will help not only the obviously super specialist will come into the picture, even the primary health care center, even the physician sitting there can manage the patients very well with the CDSS support. So technology, I believe, plays a huge role and should be utilized. And in awareness also, now we have started seeing ads on obesity. So why not coming from government, like in between the ads, diabetes is a chronic disease. It needs a regular follow-up. It needs a care. Coming from the government actually makes a huge difference. And of course, at our level, individual level, clinics levels, diabetes self-education and making structured protocols for follow-up will really help.
Thank you. Let me just move on now to Dr. Shotinath. We hear multiple things, but we should do a little bit of this and a little bit of that, which is actually the reality. But given your exposure to sort of multiple decades of diabetes care, with our problems of limited resources, would you prefer to focus primarily on policy reform, prevention programs, new therapies, or just a whole new health system redesign? If you were in that position to dictate, what would be your preference? And then what exactly would you do there?
It's never easy to answer a question when it comes from Prof. Nikhil Tandon. But since morning we have been discussing these issues in bits and pieces, and I think I'll put my money on primary prevention programs. And these would involve not only the primary healthcare providers in the form of medical officers, but also upscaling the nursing services, as Professor Kunti pointed out. And in West Bengal, we have now created a model called West Bengal model. This is mainly for type 1 diabetes now, where in all the district hospitals and health centers, we have trained the nurses and the medical officers as to how to make a diagnosis, and we have provided insulin for free and glucometers for free. And any complication, those centers are linked through technology to the nodal center back in Kolkata. So patients get referred. So that's a model. Now, ASHA workers have also been involved in this model, and this has now been endorsed by the NCD program, Government of India, with support from UNICEF. So not that things are not happening, so I would like to start on a positive note that things are happening. And doing a little bit of homework, I came to know about a program, I was not at all aware of this, which is running in this country called the 75-25 national program, where the aim was to put 75 million people with diabetes under structured care by end 2025. And audit shows that 90% of that target have been achieved. So 75 million people have been connected through technology to their primary healthcare providers, and regular audits are also taking place. So, which is something very promising. I think we should take this forward. Of course, AI-enabled primary prevention program would be more likely to be of use in terms of its scalability and other advantages. Let me talk about WhatsApp. I don't know how many of you know that at this point in time, India has 853 million WhatsApp users, right? So you send messages, not that obesity is a chronic disease and needs to be treated all the time, but diabetes is a problem, get yourself screened, and things like that. And finally, very quickly, actually, I wanted to ask Dr. Kamlesh, you spoke about diabetes causing a distress in the white populations. Indians kind of take it in a more relaxed way, blame it on the God. So diabetes distress is less in Indians and more in the Western counterparts? Thank you.
It's when they get the diagnosis, there's a sense of shock when you tell white people. When we tell South Asians, they're oblivious to it. You say, well, everyone in my family's had it, I knew I was going to get it. It's that they think it's inevitable, they can't do anything about it.
Thanks. So in the interest of time, we're trying, well, with partial success, to try and catch up the time we lost earlier in the day. I'm going to go to, as they say, we're saving the best for last. We'll ask Dr. Mohan this question. And instead of a holistic question, which I asked Shatinath, I'll want you to give us examples of. So you worked on, like nutrition modification, the rice. Similarly, looking at models of physical activity. As a sort of advice to this audience, based on the evidence that you've generated, what would you like to share with us?
So the thing which comes out very strongly again and again from national studies, international studies, is the high carbohydrate that we take. And this has been shown across India, not just rice in the south and the east, but also north and the west, where wheat is consumed. Carbohydrate is 62% of the total calories from the INDIAB study. Now, going on a very low carb diet is obviously not sustainable, as many of the fad diets have tried, and they're not sustainable in the long run. So what we did was we did mathematical modeling to see how much of that carbs has to be replaced by what. And it turned out to be very simple. If you're able to change 5% to 10% of the total calories that we consume and reduce the carbs and replace it with protein. So we tried different scenarios. Can we replace it with another? We discussed millets earlier here. Or other carbs, didn't work. Can you replace it with fat? Even with healthy fat, didn't work because the calories goes up. Now if you replace it with protein, and it turned out that the best protein was plant protein. But even animal protein was okay, but the best protein was plant protein. So we can replace on the plate, the thali, we're going to have lunch now. So you put little less of the rice on your plate and look for the protein and put little bit on your plate. That seems to have a huge public health message. Second, in terms of physical activity, Kamlesh mentioned, and somebody else also mentioned, that even 500 steps is very important. If we can make the whole population increase the step count, and if you're not able to do the step count, we have now started socially acceptable things like tanda, dance. Whichever form of physical activity that is suitable to the community, at that particular age group, or for women, or for men, or whatever is physically active, but move. So if you're able to increase physical activity, and these two things you're able to do. The third thing that we talked about, social media saying that A1C of 8.5, there are even people saying there's nothing called diabetes. High blood sugar is what God gave you, and God meant you to have that. So if it's 400, 500, it's okay. It's not a disease, just live with it. There's nothing called cancer, there's nothing called diabetes, there's nothing called anything. There are people, even our own physicians are talking about that. So we know that higher A1Cs are harmful. People stop going, you all said that, the people stop going for checkup because they feel good. So the third message is go for your checkup. Because these are silent diseases, these are silent killers. Your blood pressure or your sugar or your cholesterol don't produce any symptoms. If you go to the doctor and have a regular checkup and keep those parameters, A, B, C. In our long-term study for which I got Harold Rifkin Award, A, B, C, A1C control below 7%, blood pressure control, and C, the cholesterol control. If you just do the A, B, C, a little bit of D discipline also helps. But if you just have the A, B, C under control, people can live up to 40, 50 years with type 2 diabetes. So that's my message.
Thank you so much. I'm sure there's a lot more we could have discussed, but in the interest of time and with permission from the panelists, I think we'll draw this session to a close, and I'll hand it back to the organizers to tell us what's next in store for us, what percentage carbs and what percentage protein.